So if everyone, we always like this, everyone can feel free to keep their cameras off for the introduction and even for the panel presentation. But then for questions afterwards, then it would be wonderful if people could turn their cameras back on.
So you do not want to see our faces. That's what you're saying.
Well, I actually can't. There's I have two screens in front of me with the presentation up, and all I see are like lists of a few people. So I probably won't be able to see people's faces. But I'm gonna spotlight our panel speakers during the panel conversation.
Good idea. Then I'll let my cat sit up on the desk for a while.
Then put your cat back. for questions afterwards.
Yeah, well,
depends what kind of cat.
These are important details. Here he is.
Oh.
And he keeps my lap warm during these Zoom sessions.
When I'm home, my cats are always, I don't know, they find the exact moment when I'm speaking, that's where they decide to crawl right in front of the camera.
A lesson in humility.
How come I can't see the chat in my view? It's amazing. I think I know how to use Zoom, and then I realize that I have so much to learn. But I think I'm going to blame it on COVID as well. Have that excuse for the next little while. I think we'll wait maybe one more minute and then we'll start. People are logging on. Yeah, COVID is the excuse for the next little while. I had COVID about a month ago and I have COVID brain.
Naomi's COVID was why this session had to be rescheduled, because the COVID brain was real.
At the time, no, I just said due to illness. I wasn't sure if I wanted to make my COVID public. Okay, I think we are good to start. And if anyone feels like they missed a lot, we will be recording this and we're still working on the best way to post it. So we'll keep everybody appraised in the listserv. So, Catherine.
Awesome. Hey, everybody. So this may be a little bit of a repeat. We're going to quickly go through some things, understanding that not everyone may have made it to the first NPPCE meeting back in January. We appreciate you guys being here today. Myself at Emory, Naomi up in McGill in Canada, and Amy Trowbridge at the University of Washington felt like we needed to start this group to really capture all of the people in our field who are really most interested in being an educator in palliative care education, and potentially even educational research that's going on. And so really wanted to create a community similar to like Peppercorn or Pippin, but for those of us who see ourselves as educators. Next. So if you have made it here just through word of mouth, but and forwards of email chains or things like that, and you have not yet registered through REDCap, you can use the QR code on the screen to register for the group. At the end of the registration, there will be a little blurb of text that tells you how to also join the listserv, which is through McGill. And you can join the listserv, and Naomi will make sure that we are all getting connected and sending out emails. So today our focus is going to be on just a little quick reintroduction to NPPCE, and then our featured spotlight is really involving bereaved parents in pediatric palliative care education, which is super important, and I'm really excited. So if you would like, you can feel free to throw in the chat kind of your name, your discipline, like AKA, are you a pediatric palliative care doctor or a social worker or a pediatric oncologist or NICU physician, where you work, AKA the city or institution you work in. And if you would like, also who you teach, like fellows, residents, nurses, whoever you would like. And we can, so that way we starting to get to know our community, at least what is possible to get to know each other through this virtual environment. So what the Network of Pediatric Palliative Care Educators is we are a community of interprofessional educators. We consider ourselves everything from novice to expert and mentees to mentors. We see ourselves as a place to forge new collaborations with your colleagues across the world, and a place to grow your teaching skills and get feedback on your educational works in progress. We are not a very specific curriculum like Epic Peds. I know Justin Baker's on here. Hello, Justin. And so we are not Epic Peds or LMEC or a very specific curriculum. Those are very much still out there and accessible for everyone, and they should definitely register for those if they have not yet done so. We are not a clearinghouse for curriculum like the MedEd portal, which is a peer-reviewed place for your curriculum and educational works. We are not a place where we plan on teaching palliative care, like meaning we are not going to have talks about how to manage dyspnea or how to manage pain or how to titrate opioids. We are not yet a funding source for educational works or for research. And we're not sort of like an advocacy organization. This happens through the AAP and through the Pediatric Palliative Care Task Force and other organizations, although we are liaising with people from those organizations. And we also know that this is not going to meet everyone's needs, but we're going to do our best. We are growing and adapting and learning, and this is, meeting too. So we will keep working on it, and please send us your feedback and ideas as we continue to grow. So our mission is to advance access to and quality of interprofessional pediatric palliative care education through a community for collaboration and dissemination of educational best practices, research, and resources. And our vision is really to transform palliative care education through organization of an interprofessional community. So thank you guys for showing up and being that. An interprofessional community of educators with the goal of improving care for children with serious illness and their families. We are many, many different things. We have many people who are physicians. We have residents, fellows, all variety of nurses, researchers, child life, psychology, social work, spiritual care providers, and many others. About 85% of us have a primary or secondary focus in pediatric palliative care. About 15% of us have a primary or secondary focus on home-based hospice and palliative medicine. And sadly, only about 50% of us feel connected to an educational community in palliative care. We have, as a community, received many different types of education, obviously lots of informal peer support, mentoring and coaching, didactic and lectures, workshops, conferences, train the trainer programs like we've talked about. Some people have done an educational fellowship or certificate program or master's program as well. And what do we do as educators? We have lots of people who serve as educators in a very significant way. Lots of us participate in what we would consider bedside teaching, precepting, or didactic lecturing. A good number of us participate in curriculum design, lead a course either locally or nationally, or have a formal role in your graduate medical education department. And less than 20% of us have formal roles in nursing, undergraduate, social work, or other professional school roles. So the focus over this next year is going to be on a few different meeting types to give variety. We're going to have works in progress, and people who have educational works in progress are more than happy. We are more than happy to have you participate and present your works. We have best practices in education, or what Naomi called the spotlight today, because we realized we don't actually have a quote unquote best practice. And we have collaboratories where we can discuss common challenges, and then certainly networking in breakout space. So our tentative schedule was that we had a first meeting in January. This meeting was rescheduled from March until now. Our next meeting will be in May about using improv in palliative care education, and then in July on anti-racism in education. And then we'll have meetings in September and November that we are still figuring out. So as you guys know, we have a listserv. We would like people to be respectful. We know we already, if you're on the AAP listserv, we all already get inundated with a lot of email. So we're using this listserv for questions, connection, and networking related to education in pediatric palliative care. You're going to hear that theme repeatedly around sharing thoughts and ideas and feedback on palliative care education, or job postings are okay if it has an educational component to it. We do not want the listserv to be a forum for clinical questions like, I have this difficult patient case, can you help me with that? You don't need to send regrets or notifications if you're running late or other things like that, or really just straight up clinical job postings that there are already other forums for. Just for a reminder that when you click reply to an email, you are replying to the person and also the entire listserv. So if you would like to just reply to the person, then just, click on the to line and remove the listserv email. If you have an idea that you would like to present, we would appreciate you guys reaching out to us. This community is getting large, and Naomi, Amy, and I do not know all of the amazing projects that you all are working on. There are so many things we realized that we're hiding behind the scenes, and that was partly why we wanted to form this group. So I'm sure there are many things you're working on that we just don't know about. If you would like to present something, you have an awesome topic, you have a work in progress, please reach out to us. You can email any of us directly, or you can email the three of us together at npc-requests@list.mcgill.ca. And then if you would like to email the entire listserv, which FYI has over 350 people on it, that's nppce@list.mcgill.ca. And that's it. I'm going to turn it over to Naomi.
Thank you so much, Catherine. It's always so weird when I'm talking and I can't see people. So just a quick agenda for today. We already had a little introduction to the network of pediatric palliative care educators, or what we call NPPCE. I am going to just give a very, very, very brief theory introduction and a very brief introduction to our panel speakers. There was much more detailed information in the reminder email that went out. And then we will have our panel presentation. So during the panel presentation, I'd actually ask that you keep your cameras off, and you can feel free to send questions in the chat or just write down your questions for afterwards. And then we're hoping that we'll have about 15 minutes for questions at the end. And then who knows, maybe future NPPCE topics will come up in this conversation. So my initial plan was to have everybody just put some information in the chat, like why would we even work with parents or patients in pediatric palliative care education? But even with my really fancy setup over here with 2 monitors and everything, it's actually very hard to see the chat. So I'm going to skip that, and I'm just going to, you can think to yourselves about why we would involve parents or patients in pediatric palliative care education. And then I'll just do my very, very, very brief theory blast, the term I'm stealing from Tracy from last session. So one of the theories, or one of the types of learning, is called narrative-based learning. So according to that, really is the theory that stories help learners explore different perspectives, experiences, different emotional responses. And that actually aligns very nicely with constructivist learning theory. I'd like to consider myself to be a constructivist, where according to this theory, learners actually actively construct their knowledge within specific contexts, and stories and other information helps to contextualize the information that they are receiving. and helps to contextualize what they're learning. So there's actually more and more studies that have been done on involvement of patients themselves. Most of the studies are in patients themselves, and also in family members, showing that patient or family involvement in education, because it directly incorporates the patient and family voice, this experiential element and the I can't speak today. Authenticity, I'm going to blame it on COVID. So the authenticity improves knowledge acquisition. Then there is the transformative learning theory, which is somewhat related. So basically, learning a new perspective helps learners, helps us understand things as they change. So hearing a parent or family or patient perspective, I'm missing words here, brings in a new way to view things and actually transforms the learning experience. The presence of this may actually increase learner curiosity and empathy. I forgot to say my disclaimer. This is by no means a complete review in the theory behind involvement of parents or patients, or in some literature, it's called experts by experience. So I am fully aware that we could probably speak for hours about this. But lastly, involving end users in the educational process can actually better align the educational priorities with the actual needs perceived by patients themselves or by the parents themselves and the family members themselves. So as I said, I'm just going to give a very brief introduction to our speakers. Danelle Shu, this is in alphabetical order, not in order of preference. So Danelle Shu is a pediatric palliative care advocate, educator, writer, and speaker. And all of this started from her own experience as Levi's mother. She's parent, faculty, and co-investigator with the University of Minnesota's Pediatric End-of-Life Skills Training. She's my former colleague. She's also a member of pediatric palliative care work groups in Minnesota and nationally. Deborah Dokin, she's a family leader with a passion for healthcare improvement, which stems from her own experiences within the healthcare system with her 2 infant children and her husband. She is the coordinator of patient and family partnerships with the Institute for Patient and Family-Centered Care. And there's a lot more information in the bios that I sent out in the email. Lisa Clark is a psychologist with the Quality of Life and Palliative Care team at St. Jude's. She's the coordinator of the bereavement program and the Quality of Life Steering Council. And Wendy Avery is a pediatric palliative care parent advocate, educator, and mentor. And this all started with her own experience as Nick's mother. She's one of the inaugural members of the Family Advisory Council at St. Jude. And for the past 13 years, she's been involved in planning and development of multiple support and educational programs at St. Jude. Okay, so I'm going to end my show here. And please bear with me while I switch my share. Stop sharing. Okay. Okay, and this didn't work as well as I thought it would, but I think, is it possible for everyone, aside from our panel speakers, to close their video cameras? Let's see how well this works. Okay, so we have, I think this is okay. Okay, so thank you so much, Deborah, Danelle, Lisa, and Wendy, for agreeing to be a part of this panel discussion. I'm hoping that we can get into some interesting information, and if there are questions afterwards, then we can continue the discussion on the NPPCE listserv. So to start, I thought we'd get into some background information about parental involvement in pediatric palliative care education. So Deborah, can you tell us a little bit about how you first got involved in pediatric palliative care education? I know you were involved in the IPPC project, and I kind of think about this as one of the original pediatric palliative care educational project that was quite some time ago. It was really innovative in involving parent faculty. So how did the idea of parent faculty come about?
Well, first of all, it's amazing to see some of the names in the chat, because there are a number of people who were involved over the many years of the IPPCE, as we referred to, the Initiative for Pediatric Palliative Care. I think to describe how I got involved and how IPPCE involved parents, it started from the very beginning. I had been fortunate enough along my own personal journey to meet a number of healthcare professionals who were really committed to family-centered care. And one of them was someone who very much was involved at the very beginning of the IPPCE project. And she said, if we're going to talk about family-centered care for children with life-threatening illnesses, which was an early name of the project, we can't start this project without having family members involved. So that's how I was invited to be a co-investigator. And then later, I actually became the associate director of the program. So in terms of the planning for the project and its operation, there was always the family voice there. But really, the family voice was incorporated in every part of the project. There was early qualitative data gathering with surveys, but it was of both clinicians and family members. When we developed the curriculum, the sort of heart of the curriculum is a video series. And almost all of those incorporated the voices of parents and family members through, we actually interviewed people with a film crew. We were fortunate at the time to have some good funding. So when we got to the point of disseminating the curriculum through the regional retreats, and ultimately there were 21 of them, it was a no-brainer then. Families had been involved all the rest of the way through. Why would you not do it then? And I think in a later question, we're going to talk about actually how parents were involved in the retreats.
Thank you so much, Deborah. And what about you, Danelle? How did you get involved in pediatric palliative care education?
I was first involved while my son Levi was still alive. He was 4 years old at the time. And I was invited by Jody Chastrick, who was one of my son's pediatric palliative care nurses, to sit on an advisory council, a coalition, actually, our state pediatric palliative care coalition, and just said, hey, we're missing the parent voice in our coalition. Would you like to just come and be a part of the meetings? And then just from being present at those meetings and the conversations that happened there began to be some very organic invitations, many of which began with Jody's invitation saying, hey, I'm doing this podcast episode for CAPC. I'm doing a continuing ed course. I'm doing LNEX pediatric workshop here in Minneapolis, where we live. And just continually opening the door and I think on one end, advocating that a parent should be present at all of these different settings. And then turning around to me and saying, hey, Danelle, would you like to join us? Would you be a part of this with me or with other collaborators in the process? And so it just kind of became one invitation at a time, slowly but surely.
Thank you so much. What about you, Wendy? How did you get involved in pediatric palliative care education? And two-part question. And then how did the program at St. Jude start?
Well, oddly enough, my involvement, very much like Danelle, happened organically. So my involvement as a parent educator at St. Jude happened just a couple years after Nick died, when I was invited to be part of the original Family Advisory Council at St. Jude. It was just 2 years after Nick had died. He was 15 years old and he died of leukemia in the ICU at St. Jude. At that time, St. Jude had a very small palliative care department. It was just 2 physicians and 1 nurse practitioner. One of those physicians is now our chief koala bear, and I see him here in our meeting today, Justin Baker. So I actually met Justin when he was a fellow at St. Jude, and he was brought into my son's ICU room by our primary care physician at St. Jude because he thought that we would get along well. And he just randomly brings this fellow in here, this young guy, into my son's room in the last week of his life when Nick is in a coma. I knew nothing about Justin Baker, and that's how we first met. And after Nick died, I didn't see him again. I was invited to be on this Family Advisory Council, and in he walks one day into our meeting and with the other physician, and they wanted to meet up with the bereaved parents that run the council and just talk about our experiences and see, what improvements we could make in their department. So around the same time, they also developed a 2-day educational offering at St. Jude called the Quality of Life Seminar. And at that time, they asked if I would be willing to attend the seminar and share my perspectives and experiences as a bereaved parent. And that's the very beginning of what eventually evolved into our parent educator program.
It's so amazing. There are so many similarities in the stories that we hear from you. Next, I wanted to talk about the parental roles in pediatric palliative care education at different institutions, because even though it seems like many of you took kind of similar paths, involvement of family members in pediatric palliative care education may look very different depending on the institution you're in, the program you work with. So let's start with, I'm going to get all 3 of you to talk a little bit about what things look like where you are, where you have worked. So I'm going to start with Danelle, and then we'll go with Deborah, and then we'll go with Wendy.
Well, I'm involved in a end-of-life care skills work group, and the work group hosts workshops for fellows, 1st and 3rd year fellows at the University of Minnesota. Stacy, I see, is on the call, and she's a part of that. And I am one of 2 bereaved parents that are a part of this. We've been involved from the very beginning. Dr. Goloff invited us initially just to say, hey, will you just come observe? We're doing this workshop. I think parents should be involved. I'm not sure how. And just said, would you just come and observe? And before the end of the first workshop, the fellows, the learners, were engaging us as parents just by being in the room and being in that safe space. It's an immersive workshop. It's in partnership with the Simulation Center at the University of Minnesota. And there's 2 immersive conversations that happen with standardized patients. They call them SPs for their acronym. And then also a skills workshop. So they're the actual end of life, moving on to hospice conversations with 2 different case studies, a newborn and then also a teenager. And then the skills workshop is the actual skills of a compassionate extubation, and on talking through several aspects of a particular young boy's situation or case study. And so as parents, we're involved in the development of the curriculum, the continual reshaping of that curriculum as we learn more and more about how to keep improving it. We're involved in the training of the standardized patients. We did one just earlier today, which was exciting to have both of these things on the same day. And then we're involved as parent faculties. So we sit side by side with providers and professionals in the field. It's an interprofessional environment with social workers, nurses, physicians, and a number of different providers. And then we're involved in the feedback process, the observation process, in the actual workshop, and then also the follow-up process in terms of some follow-up conversations, looking at the effectiveness of the curriculum and continuing to refine it.
You're making me miss our program in Minnesota. Now, what about you, Deborah? What does it look like where you are, where you have worked?
Well, I'm going to talk specifically about the IPCE project and what it looked like there. So, and this is also talking about after the project did have a research phase and a curriculum development phase. But as I mentioned earlier, we then disseminated the curriculum through 21 retreats that were across the country and in Canada as well. And the retreat design was really built on the foundation that everyone is a teacher and everyone is a learner. And we often refer to learning across boundaries. And a very big boundary in traditional education is in healthcare is quote professionals and patients and families. So in addressing those boundaries, we really use conscious strategies to kind of flatten that hierarchy that we're all used to in healthcare. So the retreats were built on a workshop model. So they were very interactive versus being didactic. There were no keynoters, literally no keynoters. We chose our faculty, our professional faculty, largely through people who would not have to be a keynoter. And another small thing on name tags, no one had titles, just your name and where you came from. So families really were educators almost in a two-tiered way. Every family member who came to the retreats, and they came as members of interdisciplinary teams from organizations. So every family member really was an educator. And then they returned with their teams, hopefully to put this in action. But then selected family members also served as designated faculty who led the small group discussions during the retreats. And then also families served on the regional planning committees who worked with largely myself in organizing the retreats. So there is a great resource, and I know this project took place a while ago, but I think so much of the learning still applies. And there is an article in the Archives of Pediatrics and Adolescent Medicine that really summarizes everything. It's and you can look it up. The first author is Millie Solomon, and the title is Learning That Leads to Action.
Thank you so much. I'm actually also wondering if your group also put together a guide that's not as easily findable online on PubMed. So I think I can figure out with you how to potentially make that a little bit more accessible to our participants today if they want to look at it, because I know I found it very helpful. Thank you so much. And Wendy, what does it look like where
Well,
you
the parent educator
go?
program, yeah, at St. Jude, the parent educator program, it's just really grown into something I never could have imagined when I was sitting as the only parent in that first quality of life seminar. It's crazy for me sometimes to look back and think how much has happened and where we are today compared to where we were then. So today, bereaved parent educators continue to teach at the Quality of Life seminar. We also teach and lead table talk at LNEC several times a year. We lead a half-day session highlighting palliative care principles and communication skills with our new St. Jude Fellows during their orientation. And then we continue to have follow-up sessions as they progress throughout their fellowship. And those have become really, really great relationships for us between the fellows and the parents, just to walk through their fellowship with them. And they very quickly feel comfortable enough to come and ask us the hard questions. Maybe they've been in a situation where they are talking to someone about their child's impending death, and it's been uncomfortable, and maybe some things have happened that they didn't feel went well. Well, they can come and ask us, this is what happened. I don't feel good about it. What could I have done better? And we were able to talk through those things. And it's been really great on both sides for the parents and the fellows. So we've also led sessions and presented at St. Jude Grand Rounds, at Schwartz Rounds, at the Pediatric Palliative Oncology Symposium, and at a number of national and international conferences over the past decade. Over the past few years, we have added adult siblings and grandparents to our program and have intentionally focused on increasing diversity within our pool of parents and family educators. And that's really been great and a really important thing that's been happening.
I think hearing about all three, the work that all three of you has done really just motivates me even more for all of the work ahead of me in my new career over here. I'm just very excited. So Lisa and Wendy, how do you actually prepare parents to actually jump into the educational role? Because a common concern I have had, or I have heard from various people and trying to advocate for this is, is it going to do harm? How do we make sure that they're adequately prepared? Are we going to just make them really upset and they're not going to be able to focus on teaching? I'm sure all of you have heard a lot of those things.
Well, as our parent educators as our parents who want to become parent advisors are onboarded through our patient family centered care, they learn to share their stories, and it's regardless of the role that they plan to serve in. And then when they are placed in a parent educator role, they receive additional training, which they learn about sharing the parts of their story that are appropriate to the specific educational event, the audience they'll be speaking to, the topic being discussed, the time limitations, and how to share their story in a manner that moves the audience toward the objectives of the event. And we've developed parent educator training manual with the help of our parent educators, which in addition to enhancing skills related to sharing their stories, also has information about role expectations, a description of the recurring educational events, how to prepare for them, basic group facilitation skills, understanding and respecting boundaries, conversation facilitation skills, creating an inclusive environment, encouraging diversity, and we also include debriefing questions. And for many of our new parent educators, they just may simply observe the first time at an event, or if say there's a small group breakout, we may have them paired with an experienced parent and they'll sort of shadow. And I guess the biggest lesson that we've learned along the way is to make sure we ask staff who knew the parent or knew the family when they were involved in care, how what their thoughts are about this family or the parents being involved as educators or as advisors overall. But by a lot of times placing parents in other roles first, some of the other opportunities as parent advisors, we get an opportunity to see what their strengths are and to make a determination whether they would be appropriate as a parent educator.
Naomi, I don't know if you can see the question below, but it kind of directly relates to
Oh.
what Lisa was just saying. Does the choice of families as educators have any particular characteristic, and how is this invitation made, or who makes the invitation?
So yes, the people who are asked have to be able to express themselves appropriately and to have good conversation skills, good interaction skills, and again, we vet very carefully to make sure that parents are stable. And a lot of times parents will ask to be parent educators, and then other times when we identify someone who we think a parent advisor, as we may see them in another role and think that they would be good as a parent educator, we may ask them.
I think this is a really great question, and I want to open it up for you, Danelle, as well as you, Deborah. Just a quick highlight kind of how the parent faculty was chosen in the first place. Oh, and Deborah says, okay. And also, Deborah wants everyone to know that a lot of this is actually covered in the best practice document, which I think would be a really helpful tool to share with everyone. So just, I don't know, quickly, Danelle and Deborah, I don't know if you wanted to add anything, or Wendy as well. I didn't mean to leave you out.
Well, in the IPCE project, we relied on the organizations who came. It was a requirement that you come to the retreat as an interdisciplinary team, and that team included parents. So we relied on the organizations themselves to select the family members. But we had, and that's part of what's covered in the best practice document, we had certain criteria that we urged people to consider. And we also really emphasized that healthcare professionals who worked with these parents knew them very well. And in a certain way, they should rely on their own hearts to guide the decision.
And that's actually when I had invited Danelle and Kelly McManaman was kind of our other initial parent faculty member at the University of Minnesota in our end of life education. That's exactly what I did. I knew both of them for caring for their children, as well as then kind of teaching afterwards. I did do a little bit of teaching with Danelle afterwards. And my heart told me that not only would they be a perfect fit, but that they really that they could share, like Danelle says, Danelle would say when we give our workshop, Levi is always teaching, so they could also teach and share, help their child continue to teach through that workshop, through everything. Now I'll go back to everybody. Yeah.
I saw Justin's comment and it made me realize that I failed to mention that another way that we prepare our families for these events is that when staff request a family member or a parent educator, they have to provide the parent with a description of the event and the objectives, the purpose of having the parent in the presentation or the educational event, and what they're hoping will be the added value of the parents' participation, and they to provide them with what they anticipate the size of the audience and the makeup, who's going to be in the audience, and how much time they have to present. But very, very often our parents are involved in the development of the educational event. So there is a back and forth between the parents and the providers, and we really do see them as partners in the educational event.
And thank you so much for sharing that. And I think that's a really great question, because it gets me thinking that almost when I worked with Danelle and Kelly at the University of Minnesota, we almost did things backwards, because we really didn't start with them as partners. I started with them as observers because I really didn't know where to start. And then we kind of evolved with, well, I guess the workshop without me kind of evolved to really have them involved as more partners in this whole process. Did you want to say something, Wendy? I see your mic is open.
Yeah, I'll just add to that and kind of segue into, we were going to talk about some of the biggest challenges and lessons learned. One of the biggest challenges for me was that in the beginning, I was the only parent educator. And there were so many educational opportunities and requests for input from parents. And I'm one person, and I live in Ohio, and St. Jude is in Memphis, Tennessee, 750 miles away. So, like I said, our palliative care department was still really small. We had no bereavement coordinator, and this growing interest within the institution to hear the bereaved parent voice, like, really made us need to figure things out really quickly. And this question that was put to us, how was this invitation made to parents, and who made it? For us in the beginning, I remember sitting in Dr. Baker's office with him. It was him and me and a pad of paper and a pen. Like, what do we do next? Everything just exploded all at once. And we knew we needed to get to work to find parents who would make great parent educators, so that there would be lots of voices and stories and experiences to draw from. So in the beginning, how the invitation was made from us was me walking up to parents who I had gotten to know over a couple of years. They were bereaved parents. They had come to our Day of Remembrance, and just saying, hey, I think you would make a great parent advisor at St. Jude. What do you think? We're looking to onboard some parents pretty quickly. We need to get together and figure out how we're going to develop all this programming. And that, along with Dr. Baker, we were able to pull a small group of parents in who were great. And Naomi, it's just like you said, it's like, and Deborah, your heart tells you, these are the parents that I need to ask to do this. And we were able to pull that small group together. And that is how the initial invitation was made by us, because we really needed some parents to do this. And it has changed, obviously, as the program has evolved and all of that. It's become obviously a lot more formal now, and there's training involved, but that's really how the invitation was made in the beginning. And one of the challenges for us, or one of the biggest lessons learned for us, after that first quality of life seminar in 2010, the feedback was extremely positive. And so we decided, we'll pull in several more bereaved parents who will ask to attend the next quality of life seminar. And we'll add to that group of parents, except we had not put anything in place to train parents. And so we pulled them in. Not surprisingly, it did not go well. Justin remembers this, I'm sure. And this was a huge lesson learned for us that, you know, even though bereaved parents are just simply sharing their stories and experiences, they don't always know how to do it in a constructive and focused manner. And it can be a disaster sometimes. So it was then we started to develop the training for our parent educators that, that Lisa shared with you earlier.
Thank you so much for sharing that, Wendy. It's very true. Sometimes they don't know how to do it in very constructive ways. Danelle, what about if you could share some of your biggest challenges and lessons learned while doing this work, and then we'll go on to you, Deborah.
Yeah, so one of the challenges, as you've mentioned, is just learning to run while running. Just as this started as a pilot project that Dr. Goloff initiated with the Sim Center at the University of Minnesota. And so figuring out how do we implement this while also, involving bereaved parents, and just kind of seeing it take off and continuing to refine it as we go. Something that was really helpful in that process was that Kelly, the other bereaved parent, and I were brought in at the same time. So we had someone to bounce ideas and conversations with, as well as bring both of our voices and our unique perspectives. Kelly is also a social worker by training in the adult context. So she also brings those skills and that information as well. And so having both of us involved really helped the role grow, and, you know, just that challenge of learning how to run while running. Another challenge we've come across that the Sim Center is very good at, in the simulation environment, they have these standardized patients, which they train, and they have some very beautiful skills and tools on debriefing. And I don't mean simply like what we've learned, like a harvesting debriefing, but more of a debriefing in the role as a standardized patient. And Kelly and I have seen that process in action and the results of that. And her and I have done a lot of informal debriefing, just knowing by being in the educational setting, even presenting ourselves professionally, so to speak, our love for our child and our grief as a bereaved parent does get touched by being in the educational context. And so in care of the whole person and care of ourselves, we're working towards learning more from the simulation center and the tools that have been developed in that context to develop a debriefing process for us as parents. And then as we bring more parents into the process, just to give some closure, just kind of, you know, bring the door around closed at the end of the event, not just end with how did the event go as an educational thing, but touching back into us as bereaved parents and as human beings and our children being connected to work. Some of the things we've learned is that having parents, it might sound obvious in this setting, but having parents at the table in the educational process changes how the curriculum is developed. The curriculum changes shape. The conversations are different. What we think is going to be sort of the key teaching points, which still do get across, but it shifts with each learner group. And Kelly and I have been able to be a part of some really beautiful and dynamic conversations, both in the curriculum development side, but also in the learning part of it for the group of learners, as we call them, the fellows. That's been a really beautiful thing. And then something we've learned in our particular setting is that one way that equity and sustainability are expressed is by being able to pay us as parent faculty, just as other members of the faculty are paid, and at different points in the process. You know, experts, content experts in the Sim Center facilities are paid for. We're thankful to have some grant funds that have been donated through a family foundation specifically for palliative care education. And so being able to pay us as parents just to acknowledge the time investment that we have and the equity in terms of our role and participation alongside providers.
Thank you so much, Danelle. And I think we're going to end off our panel discussion with Deborah answering that question. And then we'll open up to everyone's questions, because I see that we are, of course, running behind, and we have lots of questions, wonderful questions coming in.
I'll read some of them off to you, Naomi. So
Just wait for I want Deborah can finish us off kind of in our panel discussion about challenges or lessons learned, and then we'll go straight to questions.
I'm going to highlight just a couple of challenges that are more infrastructure ones. And I think it is, I now am a staff member at the Institute for Patient and Family Centered Care, and we actually just finished doing a project about engaging the expertise of patients and families in medical education. And I will share these resources with Naomi and Catherine so they can reach all of you. But this idea of involving patients and families is not new. It's Angela Toll started in when, Naomi? I mean, years ago. And it goes in fits and starts, and it doesn't, it has a hard time sticking. And I think, a big part of it is really committed individuals take on the work themselves and sort of supersede all the organizational barriers and make it happen for a while. But what really needs to happen, and it sounds like it probably is at St. Jude, that this work gets built into the infrastructure of organizations and doesn't rely on a very committed individual only. And that also would benefit the sustainability, because programs come and go. And IPSI is a good example. We had wonderful, generous funding from the Cummings Foundation and the Aetna Foundation. But then when the funding was gone, who was going to pick up the ball in terms of resources? So I think those are really key challenges to think about in starting new programs, but thinking about the field as a whole. And how is this actually going to, the momentum is going to grow, and these programs are going to not just start, but continue.
I just want to take another moment to really thank our panelists so much for the work that you've put into this and for your flexibility in rescheduling this session. And now I'm going to have Catherine lead us into some questions. I do realize that now we only have about 4 minutes left for questions according to our original time. But we'll kind of be flexible. I think if there are people who are available to stay on a little bit later and the conversation is still going, then we'll try our best to keep it going. I would say for a maximum of 10 minutes past the original time.
So one of the first questions that came up, which I think is really valid as we look at the women on the screen here, are about diversity. And I think, we know in education and in hiring practices that there's affinity bias and similarity bias to, tending toward people who have things in common with you or are similar to you. So how is it that your programs are working to make sure that we're recruiting a diverse group of parents so that ideally then we can reach a diverse group of learners and more diverse parents as well?
I'm happy to address that. I think that we're doing a pretty good job of that in being purposeful about it. And we have quite a few dads who our parent educators. And when we bring on new parent educators, we've been looking at, you know, differences in the diagnosis of the child, as well as the cultural backgrounds of the families. We have several Latino parents. We have 3 parents of sickle cell children. We have, as Wendy said, grandparents, adult siblings. And so it's really just being intentional and purposeful in trying to enrich the ground, I guess, our parent educators can cover.
I was trying to decide if Deborah, you were going to unmute yourself. You were looking like you might.
Well, I was just going to broaden the question a bit, although certainly it relates to patients and families as educators, but frankly, it relates to patients and families and however they are integrated into the healthcare system. And a key mechanism are patient and family advisory councils. And the IPFCC, the organization I'm currently working for, completed a survey of all children's hospitals in the United States not too long ago. That's also available on our website. And diversity, DEI, both in the sense of do the patients and families who are involved reflect the population served by hospitals, but also are these mechanisms to involve patients and families, are they actually used to work on DEI issues that so many healthcare institutions are grappling with now? So it's indeed an issue that needs careful consideration and addressing.
I just want to say, if there are people in the audience who have ideas, who have suggestions, please feel free to put it in the chat, because we're going to save the chat afterwards. We'll take a look at it, because this really, it is a real challenge, and we're very aware of this real challenge.
One of the other questions that came from Jenny Lineberger is how to, as you create this group, how do you eventually sort of rotate parents off, even the ones that are doing a great job, but how do you sort of rotate parents so that you can get new faces and new people into the group?
I'll say that we don't really rotate parents off. We kind of keep them out there in case nobody else is available. And so a lot of times it's asking some of the newer ones first, and then if they're not available, then asking some of the others. And then, like for today, because Wendy knows the history of our program from the beginning, that's a skill set of hers, so it seemed appropriate to ask her for this one versus a new parent educator. And so it's a lot of looking at what the event is and who's got the skill set, and then just being, again, purposeful in pulling in newer parents when you can. And
I just want to affirm that what Lisa said. I think that's been a strength of our program, is that we don't actually rotate people off. We just increase our pool of parents. And so as we have events come up, we have a larger and larger pool to pull from, depending on what the topic is and who the audience is. And that's, I think, been really important for us.
And as we've had more experience with this, we found more and more opportunities to involve parents in educational events.
I also see, I see a question from David Steinhorn here that says, isn't parental involvement part of their lifelong healing from loss of a child? Wouldn't rotating them off feel harsh to them? Yeah, absolutely. That's a consideration. If the institution is the one that's rotating the parents off, if the parent wants to step back, certainly that's a different story, but it could. Now, we've had to have conversations with parents who want to be parent educators that really are better in a whole different role. So we've had to have difficult conversations with parents and say, you know, this is not quite the best fit for you, but here are some other ways you can continue to be involved. And so it's about having different options for them and finding maybe the better fit for them instead of really kind of just kicking them off. Yes, that, David, that would feel very harsh to bereaved parent for sure.
And then
I just wanted to say one thing. Then we also have to be mindful to create a culture where it's okay for a parent to say no for specific events, especially in programs that might have a much smaller pool of parents.
And then one of the other questions that I think came up in a couple different ways that I was thinking about and that Cheryl's thinking about is, you know, parent advisory committees and educator groups tend to be filled with parents who had complex children or children who had complex medical needs, and often are also filled with parents who received palliative care. And so how do you kind of encourage families of maybe parents whose children passed away from a trauma or a more sudden event, or even parents who didn't receive palliative care during their course to also be part of these parent educator groups?
I think in my role as bereavement coordinator, I don't always know whether the child had complex medical needs or whether they received palliative care. And it has more to do with the relationship that I developed with them through various interactions. And then if through that relationship, I feel that they would be good in a parent educator role, then again, I reach out to staff and ask for feedback on that. But it's not, I don't think that we necessarily go toward those type parents.
Anybody else on who's still here have any last questions or burning questions before we excuse everyone for the day and let our awesome panel of participants head out? Please unmute yourself or throw it in the chat if you do. Well, certainly, Naomi and I want to thank you all for coming today, and Amy by extension as well. She just couldn't be here today. We are working hard on our end to also create a NPPCE.org website, which will hopefully be up at some point. You know, Naomi, my and Amy's web designing skills are slightly slower than like a 12-year-old probably. So we're working on that. And then we are also working on obtaining a YouTube channel where we will post the recordings from these sessions if our speakers agree. And so we are working on both of those things. And we look forward to seeing you again in May, where we'll talk about using improv, a different style of education, but using improv in education. Thanks all. Have a great rest of your day.
Thank you so much, everybody.